Okay, everybody, today on SheMD, we have Dr. Gina Campbell, and we're so lucky to have you. We're going to talk about genetics, genetic testing. We're going to go really deep into what the future looks like, how to use it right now in your own health. So I just want to thank you so much for being here. Now, you have such an incredible story. So you started as an OBGYN, correct? Gynecologist.
Yes.
And then you went back to MIT and got a business degree?
I did. I certainly did. That was after residency, but yes.
Okay, amazing. Can you just sort of give us a little bit about how that journey went this way and ended up where you are right now at Myriad?
Yeah, I mean, so for personal reasons, I ended up leaving the clinical practice of medicine after about 10 years. That was a heartbreaking decision. I had my own practice at the time that I closed, and that was about just needing to be more available for my own children. I was going through a divorce at the time and felt like they were more important to me. And so I was lucky enough to find work with insurance companies, which sparked a whole different set of passions, because as I worked for the insurance companies, I began to understand how they think and how they impact care, both in positive ways and less than positive ways at times. And throughout that time period, I just kept hearing the divide between business thinking and medical thinking, that they would deploy business thinkers, and then once they had made a business decision, they would allow medical thinkers to sort of do whatever we did. To me, it felt like that was artificially separated thing, and that what would be optimal is if we had people that understood both the best of medical thinking and the best of business thinking. And so that's what led me to get an MBA and MIT, of course, because they're so innovative and audacious in their aspirations that I wanted to be a part of that.
How long have you been at Myriad?
I've been at Myriad about a year and a half.
Okay. And had you been interested in genetics before and the roles that genes play?
Absolutely. It's very hard to be interested in women's healthcare without really getting your mind around the importance of breast and ovarian cancer screening or cervical cancer screening. And specifically with breast and ovarian cancer, there are more genetic factors at play there. While I was working for a health insurance company, I was a medical director that reviewed genetic tests in particular for prior authorization. So I developed an expertise as I was learning about those tests as they came onto the market. So at some point I was a subject matter expert for genetic testing and ended up teaching others in my company how to think about genetic testing and how to research and deploy our medical policies.
Well, and I actually had never heard of Myriad or the MyRisk test until I met Dr. A. And what I was shocked about, and what we talk about a lot on this podcast, is that with women, we think you know about BRCA. So are you BRCA positive? Are you BRCA negative? And once you knew that, then it was sort of like, oh, okay, I've checked that off. So I was sort of blown away when I learned about this test. And Dr. A uses it on every single patient that walks through her office. You use them.
Who qualifies, yeah.
Yeah, who qualifies for it.
If you don't have family history of cancer, you don't need to take it. I do have a questionnaire in my office. If you're a new patient, you come in, you fill out the questionnaire. It's a family history. Basically, the questionnaire asks all these questions about who in your family was diagnosed with cancer. And I have them repeat that every single year, because you might not have a family member with breast cancer today, but next year this time you could have an aunt who was diagnosed with breast cancer. So it's one of those things actually that needs to be revisited at their annual Well Woman exam to make sure you're not missing anything.
Well, so can we talk about that point? You know, I thought, again, I had a grandmother with breast cancer. I was told, actually, well, that doesn't count because she had breast cancer in her 80s. And is that true?
No, that's not. So all cancers count. First of all, I want to commend you because taking a family history is super important. I myself have seen physicians who relegate that to their medical assistants, who I don't think do as thorough a job as a board certified physician would do. There are certainly more mid-level providers who do a really thorough job of that as well. But I think it's very important to understand the entire scope of your family history, not just what you think counts. And oftentimes getting more information than just what the primary was, how old were they when they got it? How many other cancers? Did they have multiple cancers? Were they young cancers? Were they rare cancers? There are some family histories, like my personal family history is insane with the number of terrible, especially GYN cancers that don't appear to be genetically related at all. So understanding the risk it matters, and it's a little bit complex and hard to do. And that's why it's so important to have a physician or a healthcare provider help you with it.
So I want to make an important point though. Sometimes I get families where, every other patient in that family has been diagnosed with breast cancer or ovarian cancer, and you run this genetic panel on them and they don't have any genetic mutations. I just want to make it clear that the reason they're negative is because they're negative on the genetic mutations that we're aware of, that we're testing for. There are thousands and thousands of genetic mutations out there that we haven't discovered yet. So if you have it in your family, you still have to take precautions. And that's why the lifetime risk of breast cancer is so important. But I want to go back to this genetic testing. Obviously, we can't do genetic testing on every single person that walks in, but I do it in my office on every single person who qualifies for genetic testing. Can you tell us who qualifies and how you decide that, and when insurance companies pay for it and when they don't?
Yeah. Insurance pretty reliably covers this for people that meet criteria. And if you are interested in the criteria, the NCCN publishes the most expansive sort of curated list of criteria. I looked at them yesterday in preparation for this. They're impossible to understand. They're extremely complex and difficult. I read it 10 times. And I want to say that it's very hard to figure out who meets criteria and who doesn't without the help of a healthcare provider. However, generally speaking, if there are breast cancers that occur under age 50, and it's very important that you look at both sides of the family, not just your mother's side, not just the people who you think have breasts, because men have breasts too. And in fact, like in my own family, we've had a male breast cancer. So family history of breast cancer, any family history of ovarian cancer. Also think specifically about pancreatic cancer and some of the high-risk prostate cancers. Those in a first-degree relative, which would be a parent or a sibling, even a secondary relative in some cases, that would be covered by insurance companies, not all, but most.
Did you get that?
Yes.
So for example, if you have one family member with ovarian cancer, one family member with aggressive prostate cancer, one family member with pancreatic cancer, it's very likely that you will get qualified for genetic testing. If you have two family members above age 50 on the same side with breast cancer, if you have one family member with breast cancer under age 50, and this list goes on and on. One family member under 50 with colon cancer, two family members, same side of the family above 50. I mean, I can sit here and go through those criteria, but you can go on your website.
It's getmyrisk.com.
Getmyrisk.com, and you'll see if you're qualified or not. But I think it's extremely important for patients to ask that when they go to their well-woman exam. This year, it's gotten better and better. I think we've talked about it so much that women are becoming their own health advocate, but it's still very rare for women to show up with a genetic test unless they have seen a breast specialist, they've had an issue, or they recently lost someone. And just like Mary Alice said, one thing that really upsets me is when patients say, no, I don't need to be tested because I know I'm BRCA negative. Well, BRCA, Myriad checks for 48 cancer-causing genes. I think 11 of them are associated with breast cancer, and just BRCA is 2 of those,
Right.
BRCA 1 and 2. So it's important to have a full panel genetic testing and not just talk about BRCA. So that's another point I wanted to bring up for patients. So you were telling us about insurance coverage. So 25% of patients qualify to do genetic testing. And of those patients who qualify, majority can get their genetic test paid by insurance.
I think that's a true statement in most cases. I think for those that don't qualify for insurance coverage, Myriad works very hard to make it affordable.
Right.
So there's always another way to go about getting the testing, even if you don't think you qualify for insurance coverage.
So everybody that we're clear, it's called the MyRisk with risk score. So I want to kind of go deep because there were some stats that I was like, whoa. So if you have a genetic mutation, parents, children, and siblings have a 50% chance of having the same?
Depending on the gene, yes.
Depending on the gene.
Many of these genes are inherited in that autosomal dominant fashion like you just described. So 50% would be affected.
And so the MyRisk test does 11 hereditary cancer types, and the risk score provides 5-year and lifetime risk for breast cancer. Is that correct?
That's right. Yes.
And you can do it in office, virtual care. You also have genetic counselors. So basically, let's say that you do take this test and you come back and you're BRCA positive. What's next?
So the most important thing, of course, is to talk to your healthcare provider. We do have genetic counselors who will do both pre and post test counseling. The important thing is knowing how to use this information. I think that many people resist testing because they feel like they're going to be a sitting duck, that they're going to find out they have a mutation and they think that's the end and that they just are going to get cancer, or they think it's a test for cancer, which it's not. With a positive result, there's a lot more that can be done to mitigate risk or decrease your risk, things like diet and exercise changes. But the most important thing is enhanced screening. And so we typically recommend that women undergo this testing around age 25, because that's when the enhanced screening would begin. And by enhanced screening, I mean earlier screening. I think the recommendation is still 40 for annual mammograms for women. But if you have a hereditary cancer risk, that screening would begin at 25. And then you have access to things like MRI screening, or you would do more diagnostic mammography sooner than later. And then on the back end, after screening, there are still things that you can do to prevent breast cancer, things like taking tamoxifen prophylactically, or even Arimidex, or there are some other things like risk-reducing surgeries that have been a game changer for women who, feel like they're going to be affected very young. And so they'll end up having elective mastectomies, which is scary for a lot of people, but we know that there are a lot of women who choose that route because they prefer longevity. So
I've heard this from friends and relatives. They say, I don't want to know. I just don't want to know, because if then I'm just going to, and we've talked about this on the podcast. You give a great example of the house burning down.
What I always tell my patients when they say, I'm scared, I don't want to know, I always use an example, and I say, if you're sitting in this room and the curtains are pulled, and I'm telling you there's a chance that there is a fire behind this window and your children are in this room, wouldn't you want to pull the curtain, look outside and see if there's fire? Because if you see fire, you're going to grab your children and you're going to run out. But if you don't, and you're too scared to look, you take the risk of this house coming down and basically killing you. Which option would you take? They're like, of course I want to look outside and see. I'm like, then let me look, because if I look and I see fire, then I've saved your life. And it's not true that we won't do anything about it. If you have a genetic mutation that increases your lifetime risk of breast cancer to 87%, increases your risk of ovarian cancer to 44%, increases your colon cancer to 100% in your lifetime, then we're going to do something about it and we're going to prevent it from happening. When you take the Myriad test, let's say you walk into your doctor's office, there's a simple questionnaire. You can have it from the website. You answer those questions and you'll know if you qualify for genetic testing or not. So once you qualify, you want to arm yourself, go to your doctor's appointment and ask for the MyRisk test. The reason I've used MyRisk over other companies for many years in my office, number one, I say if you know your first name, last name, date of birth, you need to know your lifetime risk of breast cancer. You need to know what that risk assessment is. And Myriad takes your information and calculates that Tyrer-Cuzick risk for you. So if you look at your Myriad report, at the bottom on the left, it says your TC percentage. And it's important to know that percentage, because if that percentage is 20% or more, you fall into the high risk category, which means you have to start your imaging as early as age 30, even if you don't have a genetic mutation. Now, if you have one of the genetic mutations, then you start at as early as 25. So one, when you do your MyRisk test, the first information is they're going to check you for the 48 cancer-causing genes. These are main genes. 11 of them are associated with breast cancer, BRCA1, BRCA2, PALB2, CHEK2, PTEN. The list goes on and on and on. So they check you for those cancer genes. And the first row basically tells you screen negative. If it's green, that means you don't have any of those 48 cancer-causing genes. Then they calculate your Tyrer-Cuzick, which is your risk of developing breast cancer over 10 years or over your lifetime. And then they go beyond that and they calculate your risk score. Risk score is the combination of Tyrer-Cuzick, which just Tyrer-Cuzick uses your history, right? Your height, weight, density of your breast family history, whether you're Ashkenazi, whether you've gone through menopause, age at first period, age at first child, and the easy questions to answer. But Myriad also gives you a risk score, but they also look into your DNA for tiny little markers. These are markers that individually don't do anything, but some of us walk around with tons of those DNA markers, right? which can increase our risk of breast cancer. So your risk score is the Tyrer-Cuzick plus these markers together. Sometimes I have patients whose, let's say, Tyrer-Cuzick is 22%, but the risk score comes back at 37%. And so you go from 22% chance of getting breast cancer to 37%. That's why that risk score is so valuable for me. And that's why I pick Myriad over other companies, not only because of the genetic test, not only because they calculate the TC score, but most important, it's all three. I get a risk score with it. And then I can look at that patient and then decide what kind of imaging that patient needs. If you have one of the 11 cancer-causing genes, you start at 25 to do your breast imaging. If you don't have it, but your risk score is 20% or more, you start your breast imaging at 30. And that means mammogram and ultrasound, and you alternate it with MRI. If your Tyrer-Cuzick is a low risk, your risk score is low risk, you have no genetic mutations, then you can start your breast imaging at 40 or 10 years before your first degree relative was diagnosed with breast cancer. For example, if you had a grandma who was diagnosed or an aunt, let's say, who was diagnosed at 45, then you have to start your mammogram at 35, 10 years prior. Now, the one thing I do different in my office, and I know it's going to be standard of care someday, even on my low risk patients, I always get a baseline mammogram, baseline mammogram and ultrasound at 35. And this is not standard of care right now. It is standard of care for Aliabadi in my office. I've done it for years, and I've just caught a 37-year-old who was new to my practice with stage 2 breast cancer because I ordered that baseline mammogram when she was 37.
I mean, you guys are both. No, you have to be your own advocate. Well, we started this podcast. What do you think is the reason that so many young women are getting breast cancer these days?
Unhealthier lifestyles. You were just talking about alcohol before the podcast. Tell us.
I mean, alcohol is the one easily modifiable risk factor that women just don't like to think about or talk about. And I can tell you from asking women how much they drink and all of these things, they get really upset when you talk to them about alcohol because they can't imagine how they're going to live their lives without that second glass of wine. And yet alcohol, it's like a threefold risk factor for breast cancer compared with, it's even more cancer causing than hormone therapy. And everybody came off their hormones when the Women's Health Initiative was published, but people still continue to drink. And we're seeing increasing drinking behavior, more drinks per day per episode of drinking than ever before.
What are the guidelines for drinking? How many cocktails can you have? How many glasses of wine can you have a week without raising your risk for breast cancer?
Well, I think the studies right now say that women should have no more than one, but I think we're getting
one a week?
No more than one a day. But I think more and more data is coming out that it should be zero.
Much alcohol.
It's so much alcohol.
That's craziness. That's 365 alcoholic drinks a year. That's crazy. I would say zero to alcohol.
But if somebody's listening and they just want to start somewhere, try to do just one a day.
Less than one a day.
Yeah.
I would say less than one a day.
Okay. So at least if you're listening right now and this feels very overwhelming, but I mean, it is actual, data proven that this 3 times it brings it up, right? 3 times more.
3 times. 3 times.
The thing I want to talk to you guys about, the 2 main factors that increase a woman's lifetime risk of breast cancer. One is family history. Mm-hmm. And that's why it's so important to know your family history. So don't come to the office and say, I don't know if my grandma had breast cancer or lung cancer. It's very important to know. And the second thing is having had a history of a breast biopsy that showed atypia, like atypical lobular hyperplasia, atypical ductal hyperplasia. Any atypical cells in the breast will increase your lifetime risk of breast cancer. So these are the 2 main factors. And that's why we were talking about family history. It's so important.
What do you do if you're adopted or your parents aren't alive and you can't get your family history?
So in these cases, for my patients, I do the counseling. And if they can afford it, then I would ask them to take the test. It's always better to know than not know.
Right.
Some insurance will cover it if you're adopted, or if you have limited family history.
Oh, really? That would be great. Not all, but some. So is it worth just sending it?
It's absolutely worth talking to your doctor about it and looking into it. And Myriad will also work to make the test affordable because we want people to have this test.
That would be amazing.
I think that people are talking a lot about data and privacy and all of these things as a reason maybe that they're scared to take genetic testing. So I know that all the big companies have, things in place to protect your data and all of that. I think it's interesting that the more women that take MyRisk, the more data they have. If we're all trying to change the world for women's health, knowing your lifetime risk of breast cancer, knowing that data, taking a test like Myriad is helping to change the world, because the more we know, the more we know.
We take every aspect of this testing very seriously. We have brilliant data scientists that work on this problem. The other thing I would say is that there is a accumulation of data that Myriad has used to develop Risk Score. This is how we were able to come up with something that served people better, because we had this library of test results. So I would say that I don't think there's a risk of breach in that sense. I think it's actually really helpful and informative that the more people get tested, the more we have information. Like, if we think about it, family history is a proxy for genetics. And now we have the ability to test genetics directly. I think it's imperative that more people get tested.
My dream is that someday this genetic testing would not really require a strong family history to be qualified for the insurance coverage. I had a patient, was it last week? I think it was on Friday, at my office, and her grandmother in her 70s had breast cancer. She had another family member with maybe an uncle with lung cancer and another maybe aunt with some other cancer, not a female cancer. And based on criteria, she did not qualify for the genetic testing, but she wanted to advocate for herself because she was so scared. So she did the test with her gynecologist, and it came back that she had BRCA1. So she calls her entire family and they all go get tested. Her aunt was BRCA positive. She runs to the doctor, does a pelvic ultrasound. They find an ovarian mass. The aunt undergoes surgery, and she had stage 1 ovarian cancer.
Nobody
but
catches
she
that.
saved her life, and she saved, do you know what I'm saying?
Other family members.
Other families. One time years ago, I went to a party and I was at the bar getting my water. And I heard these two women talking, and one of them was telling the other one that my uncle was just diagnosed with pancreatic cancer. And as I was standing next to them, I tapped her on the shoulder. I'm like, I'm so sorry, I didn't mean to eavesdrop, but you need to go do genetic testing. Here's what, I use MyRisk in my office, blah, 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 go do it. Couple of years go by, and I was at a different party, and this woman approaches me and she's like, can I give you a hug? I'm like, of course. Why? She hugs me. She's like, let me tell you, do you remember me at the bar? You told me you have to go get tested. I'm like, oh my God, yes. She's like, I went and got tested. I was BRCA positive. Then my entire family got tested. Half of my aunts and uncle were BRCA positive. And I just wanted you to know that you saved an entire family by that one comment at the bar that night. And that's the kind of awareness that, I want to share here on this podcast. This woman just had one uncle who was diagnosed with pancreatic cancer and nobody else. And half of them had BRCA. It must have been a young family, right? They were ready to go into the eye of the storm probably. But that's why it's so important to know your family history. And if you have a family member who gets diagnosed, especially at a young age, to go to your doctor, advocate for yourself, ask to get tested. And it can really not only change your life, but it can change the lives of so many of your relatives.
Your entire family, I agree completely.
And that's
an
power.
Amazing story.
That's the power of knowing. And then you can save other people that you love. So let me ask you this. Where do you think genetic testing is moving for the future? And how do you with this role that you have at Myriad and Myriad itself, where do you see them taking it?
Well, I hope that it's headed in the same direction that she hopes it's headed, which is that we will stop using family history as a proxy and actually genetically test people. Because number one, ancestry is not always known. You think you know your ancestry, but you don't. I mean, this is one of the things that Ancestry.com taught us all, is that, my dad's not as Scottish as he thought he was. And so I think that we have used family history extensively in medicine because we haven't had these tools available, but we do now. And as you pointed out, there are spontaneous mutations. Mm-hmm. So just because you didn't inherit it doesn't mean you don't have it. And so I think that the goal is to make these tests more affordable over time, so that we're doing testing earlier. But that's where the state of the art is going, is testing for a lot of this much, much earlier.
So you'll be able to know, that's, I don't know if
so
that's
much more.
I don't know.
Well, see, this is where we get scared. Yeah.
Right. Listen, there's a lot of things that are scaring us. And knowing your genetics should not be one of them. So I'm just going to put that out there right now. But it is amazing if you think of, you've said this before, that AI is now finding, in terms of testing your mammograms, like it's finding so many more. I mean, all this technology is just going to get better and better and better and better. And the genetic testing is going to get better and better and better. And we're going to learn so many more genes that it's just going to, so it is this very positive, amazing place that we're in right now.
It's life-changing.
It is life-changing.
It's life-changing. And it's literally saves people's lives. And let me tell you, let's say you diagnose a young woman with the BRCA gene, right? She's getting married, they're trying to have a family, but it all starts with self-advocacy, knowledge.
Knowledge
is power.
So thank you so much. This has been so informative. So I just want to ask you a few more questions before we let you go. What is a misconception people have about genetic testing?
I think that people think they're getting tested for cancer, that they think that if they have a gene, that means they are going to get cancer, and that is not the case. With genetically determined cancers, it's like there's an interplay between genetics and environment. It's not a 1-to-1 ratio that you have the gene and you get cancer. So I think that's important for people to know. And
I want to add one more thing. Once we know, we can prevent you from getting that cancer, hopefully, right? Like if you have a very high risk of ovarian cancer, we remove your ovaries at 40 or at menopause. If you have, if your lifetime risk of breast cancer is 80%, you can choose to do a prophylactic double mastectomy. So we do have options.
And what piece of advice would you give your daughters about women's health? From everything you've learned, from being an OBGYN, gynecologist, getting your MBA at MIT, to now working at this amazing company?
It's the same message that you're giving. It's be proactive. It is use your health insurance. That's what it's for. And there's a lot of people that only go to the doctor when they're sick or when they go for their annual exam once a year, when there are tons of issues competing for a physician's time. I would say think about the 6 issues that you want to think about and go to your doctor on purpose for a problem-focused visit. This genetic testing should be its own visit. Call your doctor up, ask to say, I want to talk about my family history. I want you, not your medical assistant, I want you to sit and review my family history with me and tell me what my options are. And in general, just to persevere. Don't just let the health system guide you. You figure out what you need and what you want. And especially if you don't, I know it's very difficult to find physicians these days. I would say my family is constantly frustrated. They have a physician they really like, and then their insurance changes or something happens and they no longer have access. Really, don't give up. Keep trying until you find a doctor that you respect, or a healthcare provider or a nurse practitioner or somebody that you feel like listens to you and takes you seriously and will take your healthcare in the direction that you want it to go.
One thing she said right before we started this podcast, which is the best advice I've heard, honestly, for patients who want to use their insurance. She told me that she saw our checklist for a well woman exam, and she said you had so many things that they need to advocate for and ask questions about. And she's like, instead of doing it at one visit with your well woman exam, divide those into multiple visits. One visit should be your family history of genetic testing. One visit should be your PAP, STD, birth control visit. One other visit should be something else, like discussing your bone density, menopause, your hormones, all of that. And that's a great advice, because if you want to do everything I tell you need to do, then you need 45 minutes, and no in-network doctor will have the time to spend 45 minutes. But if you break those visits up and write down the questions, so you go in, you're informed, and you go in, that's honestly one of the best advices I've heard. And that's a great way to look at it.
Well, and your insurance company wants you to use your insurance. That's why it's there. And they want doctors to be thorough. They want them to spend the time. It's just a matter of knowing how to work within that system.
Right.
That's really one of the best pieces of advice we have ever gotten on this podcast.
Because I complain that doctors don't have enough time to answer the 50 questions that I want them to cover at your Well Woman exam. So now we know you can go 6 times, divide them, write down your questions, go in, and, that's just amazing.
It's also easier for physicians to schedule that. Like if you call, they have a limited number of Well Woman exams and they're booked out for a year. But if you do it on a problem basis, it's less time in their schedule and they typically have more appointments available too.
Yes.
That's awesome.
Great advice.
You learned that from working for an insurance company, right?
No, I worked that from running my own private practice.
Oh.
And scheduling my own patients.
Okay, amazing. That's such good advice.
I'm
Okay.
the opposite, right? I sit like for an hour with someone
No,
and
I
I
did too. And I was always running behind. And that's how I figured it out. Pain. That's how I figured it out.
If someone listening wants to take this test, will you tell them how to do it?
So the easiest thing to do is to go to getmyrisk.com and look at the material there. It will tell you how to do a detailed family history. The holidays are coming up, which is a great time to sit with your relatives and ask them probing, embarrassing questions about their health and their cancer history and their relatives' cancer history. So know your own information, go to getmyrisk.com and then talk to a healthcare provider about whether or not you meet criteria for testing.
Okay, listeners, viewers, go to getmyrisk.com to learn more. Thanks so much for joining us today on SheMD.
If you want to own your own health, a good place to start is by following us on social media at SheMD Podcast and by subscribing to our show on YouTube or wherever you get your podcasts.
For takeaways from today's episode, visit our website, shemdpodcast.com. We'll see you next time on SheMD. This podcast is for educational and entertainment purposes only. It is not intended as a substitute for a physician's medical advice. You should regularly consult your medical provider in matters relating to your own health. Even though we share our honest beliefs on SheMD, some of the products and services we discuss may involve sponsorships or paid advertising.